Trigger points. Chapter 3. Cause and effect. Fibromyalgia patients must understand this section because your pain is directly maintained by peripheral stimuli from pain generators such as TRPs and arthritis. You need to control the peripheral pain generators before you can gain control of the pain amplifier. FM. Nearly everyone has TRPs at one point or another. Have you ever heard stories such as I broke an ankle when I was small and it's been weak ever since? The bones have healed, so why is the ankle still weak? Most commonly, TRPs were activated at the time of the break or during immobilization after, and the soft tissue damage was never adequately treated. After the TRP treatment, the ankle will no longer be weak. We have successfully treated people who have had such symptoms for decades. Many of these patients have been told they had to live with these symptoms. The patients were grateful to receive healing, but some got angry later, grieving for their lost years. Consider the man impotent for 30 years, or the woman with IBS for 25 years. They looked at TRP patterns and recognized themselves. When they learned how long TRP techs had been available, they wondered why former care providers didn't recognize the TRPs causing their symptoms. The universe has many mysteries. This lack of training is one. TRPs are not. Knowledge is power, and this book is about empowerment for patients and care providers alike. Getting to the trigger point. Myofascial trigger points are hyper-irritable localized spots in taut bands within those muscle sarcomeres you met in the last chapter. You may not always be able to feel those ropey bands, but they are there. Placing the muscle in a lengthened position exaggerates the bands and helps you locate them. Contraction knots, the lumps in the bands can be small or large, depending on a number of variables such as how many TRPs make up the contraction knots, the tissue consistencies, and the amount of fluid infiltration involved. When a muscle is burdened with one or more TRPs, it hurts to stretch that muscle out. There is pain at the end of the range of motion, so you avoid extending the muscle. This is not a sign of mental illness and pain avoidance behavior. It's illogical to avoid doing the things that hurt. Some psychologists have trouble with this concept. TRPs in each muscle cause a recognizable pain and or dysfunction in a characteristic referral pattern. Sometimes those patterns are in the area of the TRP, but they may cover several muscles. The patterns may not even include the muscle that holds the TRP because TRPs can refer pain elsewhere and can also alter sensations. Imagine having a constant itch you cannot find, or hearing a noise that you won't go away until you find and treat the TRPs causing it. Referred pain is something you already know. Angina and heart attack can refer pain down the arm. So TRPs, they can mimic heart attack and other conditions very well, keeping emergency department staff busy and frustrated unless they know TRPs. An irritated gallbladder can refer pain to the top of the right shoulder, abdomen, and up back. In the body, everything is connected. The pain patterns in this book do not have X to mark the spot of the TRP, as in many other books. TRPs can occur anywhere in any muscle, although they often occur in the muscle belly or where the muscle attaches to other tissue. They can also occur in any layer of any muscle, and each muscle layer can have multiple TRPs. You need to know anatomy to find them all. TRPs can also occur in other tissues, including scars, ligaments, tendons, skin, joint capsules, and periosteum, but myofascial TRPs have the most commonly recognizable referral patterns. Fortunately, these patterns have been mapped out, and we have a whole picture of gallery of them in this book, and we include anatomical drawings so you can find their source. Fascia contains protein that contracts it. In low back fascia, there can be 1,000 times more contractile protein than in surrounding muscles. Myofascia may form contractures slowly, a few sarcomeres at a time, even over the course of years, causing worsening stiffness as we age. Sometimes TRPs twitch. Patients may be able to feel or see that happening, as the muscle seems to jump visibly. Every time a TRP twitches, over 30 irritating biochemical and are released. into your body. These twitches can occur whenever you get a successful treatment and can be visible to the care provider. These biochemicals include nerve toxin and acidify the surrounding area. When many TRPs twitch or few TRPs twitch a lot, patients can feel extremely toxic with exhaustion, nausea, fatigue, and or extra achiness. It takes time for these toxins to be processed and eliminated, so they need to be patients. Better the toxins are on their way out rather than being stored within the tissues. TRPs shorten muscles. Muscle fibers can contract without any input from nervous system, without adenosine triphosphate, the body's main energy biochemical, and even without additional energy. The muscle is in physiological contracture, a tightened state that is different from contraction. A contracted muscle is shortened because it has been told by the nerves to tighten. A contracted muscle is shortened because the sarcomeres are shortened without any message from the nerves. This is physiological. You can't relax a physiologically contracted muscle without outside intervention. Tissues close to the TRPs develop a serious energy deficit because of increased tissue tension, which can itself cause pain. They get less oxygen. This worsens the energy crisis around the TRP and adds to fatigue. TRPs can cause dysfunctions of the autonomic nervous system, including itching, burning, redness, goosebumps, or other sensations, often in the typical referred pattern. TRPs can also cause proprioceptor dysfunction. Proprioceptors are sensory units that tell your body parts where they are in relation to the world around them. This includes the position of other body parts. If your teeth don't know where your cheek or tongue is, they can chomp down on part of you rather than on that sandwich you are eating. Your legs don't lift your feet quite high enough when you walk and you stumble over them. You are forever stubbing your toes or walking into door jams. If this happens, it doesn't mean you are clumsy. You are simply proprioceptively impaired. Not only do some TRPs cause all of the above, but also their little figurative myofascial fingers wrap around nerves, blood vessels, lymph vessels, and maybe even ducts. So you can have nerve entrapment, which can feel like you are being hit with jolts of lightning, zapped by tongues of fire, or impaled on a sword of pain. You can experience swelling of the hands and feet if TRPs are entrapping blood vessels in your neck. Your breast may be lumpy from TRP's duct entrapment. These localized symptoms are not caused by FM. Diagnosing TRPs is a challenge because they don't show on common tests, and for a long time, much of the medical world dismissed them. In 2008, the Mayo Clinic announced it had photographed the taut bands of TRPs. The National Institute of Health did a study on TRPs using this type of equipment and verified that TRPs are real. They noted that as many as 85 to 93% of chronic pain patients in pain clinics have TRPs, and almost 10% of the population of the USA have them. Stress, motor and plate, release of excess calcium, release of excess ACH and irritants, acidification, microcirculation dysfunction, lack of oxygen and nutrients, impaired waste removal, increased metabolism and energy demand, pain and dysfunction, increased stimulation of sarcomere, formation of taut bands, and contraction nodules. Cycle of misery. Trigger point formation hypothesis as we know it today. These individual links in the chain do not always occur in this order. The figure here shows the chain reaction of the integrated TRP hypothesis as we know it today. It creates and perpetuates TRPs. At first, the flattened end of local motor nerve called the motor end blade is stressed. The motor end blade responds to the stress by releasing excess calcium. The excess calcium prompts the release of excess amounts of neurotransmitter acetylcholine. The area becomes more acidic, which inhibits the biochemical that breaks down ACH. These biochemical releases result in tissue tightness, and that tightness restricts the blood supply. This makes it difficult for nutrients and oxygen to get to the muscles and for the waste materials of muscle metabolism to be transported away, resulting in a state of energy crisis. The tissue in the area of motor and plate are starving for oxygen and food and burdened with excess waste. The deforming of the sarcomeres creates the characteristic TRP contraction knot. These knots are the lumps you can feel or learn to feel in your muscles. The sarcomeres on either side of the contraction knot lengthen, creating the taut band. Within the dysfunctional end plate area, there is a situation of increased energy demand and lower energy supply that is self perpetuating. Muscles with TRPs begin the day tired, so do their owners, and become more fatigued more easily and quickly than healthy muscles. These muscles are physiologically weak. Repetitious strengthening exercises like those often found in work hardening clinics don't help TRPs. These muscles are crying out for more energy and they are given more work instead, so the energy crisis gets worse and it can all be amplified by FM. Active and latent trigger points. Trigger points can occur directly from an initiating factor such as repetitive motions or secondary to another condition such as arthritis or anything that can induce the energy crisis. They can even result from faulty muscle recruitment patterns. When a person performs an action, any action, many muscle contracts to provide the tension and stiffness required to carry out the task without stressing joints. All the muscles don't contract at the same time, but in a specific sequence or order. When good muscles go wrong, some muscles contract too early and others contract too late. With some muscle fibers not contracting at all, this state is called muscle inhibition. If the TRPs recur in spite of adequate treatment, look for perpetuating factors. These are mechanical and metabolic factors that keep the TRPs active and produce symptoms. The key to controlling TRPs is to control of perpetuating factors. TRPs are activated by acute or chronic overload. Your introduction to TRPs may come from a sports injury, inappropriate physical activity, surgery, a fall, an unexpected movement, an auto accident, or a repetitive trauma. Even with acute onset TRPs, there may be delay in TRP formation. Active TRP can hurt all the time, even at rest. The tendency is to go back away from a roaring lion. You restrict your muscle movement and the pain may go away. The TRP does not, it has become latent. Latent TRPs are like landmines waiting silently under the soil, ready to activate at any provocation. Latent TRPs don't cause spontaneous pain, but they still cause dysfunction. The muscles are still shortened, tight, weak, and in an energy crisis. Younger people tend to have more active, painful trigger points. Older people have more latent trigger points with restricted ROM and muscle weakness because, in general, they move less. They have decreased their range of motion because it hurts when they stretch TRP laden muscles. Then along comes an infection, a fall, or other stressor. Wham! Those latent trigger points activate, and there is an unexpected pain overload. This may also occur in sedentary people. Often one event initiates a TRP and another maintains it. For example, a head cold can cause many symptoms, including headache, stuffy sinuses, and a runny nose. It may also activate TRPs that cause the same symptoms. The TRPs and their symptoms may remain long after the cold is gone. TRPs are dynamic in nature. During the activation process of a TRP or while it is in the process of becoming latent, spontaneous pain occurring without outside pressure may be present in the area of a TRP. Without the typical referral pattern, even the pressure, when the TRP is in this stage, the pain may only be local. For example, a temporalis TRP may cause pain that is restricted to the immediate area around the TRP without characteristic referral to a tooth, the eyebrow area, or extended areas of the head. These transitional TRPs may be missed and the pain misdiagnosed because the characteristic referral pattern is absent. Satellite TRPs. Uneven tightening of muscles caused by TRPs can affect joints. Bones follow muscles, so the bones can be pulled a little bit out of alignment by contractured muscles. This can cause wear and tear of the joints and result in inflammation known as osteoarthritis. This process includes TRPs that can affect your jaw alignment, causing wear and tear of the temporomandible joint. Others cause gait disturbances that, if untreated, may lead to hip or knee replacement. Much of this damage can be prevented, but if TRPs are not properly treated and perpetuating factors are not brought under control, TRPs can spread. This process is not progressive because it is reversible. Simple TRPs, if diagnosed and treated promptly, can be easy to resolve. If, however, they remain untreated, your body compensates. You limit the way you move to avoid pain at the end of the movement. You set in motion habits that will further perpetuate TRPs. Stress other muscles and take time to unlearn. As muscles weaken from TRPs, other muscles are recruited to take up the work of the weaker ones. These muscles tend to be targets for spasm when others are stressed, including the trapezius, masseter, posterior cervicalis, and lumbar paraspinals. Muscles that are in the referral pain pattern of a TRP are also subject to stress. These muscles can develop TRPs too. To find out what happens when the TRP becomes many, we need to explore the world of chronic myofascial pain and fibromyalgia.